So I think I'm going to start doing some early introduction as people are coming in, getting settled. My name is Martha Francis. I'm a nurse practitioner at the Proton Center and the University of Maryland Radiation Oncology. And so I'm back and forth between the main hospital, but also I spend a lot of my time at the Proton Center. So I'm going to talk today briefly, sort of broadly about cancer and the use of radiation therapy, and then specify a little more detail specific to the Proton Center. In terms of the presentation, I just want everyone to know, very casual, very relaxed, think of questions. If you have something to jot it down, jot it down. If you're afraid it can't wait, and interrupt me, it's fine. So I'm here to, oh yeah, and we have a microphone so that everyone can be heard. Can I get a sense of how many people already come here to HopeWell, are familiar with HopeWell? Okay, so most are familiar. Anyone, it's your first time being at HopeWell? It's my first time being in this building. I've been on the property before, but it's my first time being in the building, which is really wonderful. It feels great to me. So I'm pretty happy to be here. If you can't hear me or aren't clear on something I said, please speak up. I want to make sure everyone's on the same page. So the title of this talk is called Beyond the Beam, Radiation Therapy and Its Role in Cancer Treatment. So starting off with the basics, what is cancer? Cancer is abnormal cells, but cancer can be different things. And what I've outlined here is cancers start in different places. So cancers may be referred to as a carcinoma. That's the most common type of cancer, and it starts from cells of the skin or tissues lining the organs. And the most common of carcinoma malignancies are like lung, breast, colon cancers. There's another family of cancers called sarcomas, and those cancers really originate from cells that started in bones or soft tissue that become abnormal and develop into a malignancy. Another common type of cancer that you may have heard is leukemia or lymphomas. And leukemias are cancers that start in the blood or bone marrow, and lymphomas are cancers that start within the lymphatic tissue of the body. The reason these are important, as you hear, not all cancers are the same. And depending on where the cancer starts within the body, that helps guide what's the best treatment for those cancers. And lastly, brain and spinal cord cancers. We commonly refer to it as CNS, central nervous system. And that's basically implying brain or spine, your command center. And cancers in those parts of the body obviously can affect your thinking, cognition, or your mobility, strength, weakness. So how do you treat cancer? Cancer can be treated through a multiple of different modalities. Sometimes the appropriate treatment is using all the modalities, but sometimes, depending on the cancer itself, you use one or a couple, a combination. So most commonly, when someone's diagnosed with cancer, there's a biopsy. The first question in the sort of treatment paradigm they ask is this surgically removable? What's the role of surgery? Can it be taken out cleanly? Another common treatment is chemotherapy, and that refers to chemical therapy or medication therapy, which nowadays can be delivered many different ways, from intravenous through your veins to pill chemotherapy. I have worked in cancer for 30 years. I'm old enough to know that when chemotherapies at the beginning of my career, if you were getting chemotherapy, you were admitted to the hospital. You got all that therapy in the hospital, and now there's a significant advancement in cancer treatment where patients don't even have to go to the hospital sometimes. They may go to start, but the majority of their cancer therapy is given within the comfort of home, whether that's wearing a pouch with the chemotherapy that's run through a pump, or you're giving yourself the pills at home. Radiation therapy is where I have spent my career in working in radiation therapy. We'll talk more about that. But radiation is X-rays. Just like you get chest X-rays, CAT scans, you have a chest cold, your doctor sends you for a scan. Those are X-rays. What's different about diagnostic X-rays and radiation therapy, which falls into what we call therapeutic X-rays, with radiation therapy, we can control exactly where the radiation is going. So we can direct it at a target and only deliver the radiation to that target. Whereas you have a chest cold, you're sent to the imaging center for a chest X-ray or a CT, they're imaging your entire chest cavity. And lastly, a newer form of cancer therapies, which has really transformed cancer treatments and, as a result, cancer outcomes, is the use of immunotherapy and targeted therapy. So what is radiation therapy? Radiation, as I described, it's high energy X-rays that are targeted at the target to kill or damage the cancer cells. It's delivered externally through a machine. You're laying on an imaging table. For anyone that's had a CAT scan or an MRI, that table you're laying on is very similar to what the table our patients lay on at the Proton Center. That's the most common type of radiation, is delivered externally. So it comes from a machine outside, directed into the body at the target. But there are times where we use internal radiation. And most people, I would suspect, have heard of men getting, say, prostate seed implant. That would be an example of an internal radiation delivered through the radiation seeds into the prostate to kill the cancer cells within that prostate. There are also GYN cancers, cancers of the of the uterus, cervix, where we deliver radiation directly into that site. And radiation is often used in combination with other therapies, so prior to a surgery or alongside chemotherapy. So how does radiation work? The most simplest example of how does this machine run is the X-rays, when they're directed and come in contact with the body, they damage the DNA of the cancer cell. More commonly, radiation is delivered over a series of daily treatments for a number of weeks, is the most common. Monday through Friday, weekends and holidays off for X number of weeks. And the purpose is we're giving a small dose of radiation directed at the target. And if you can picture, analogy I often give patients is like taking a little hammer, and every day you're whacking that tumor with the hammer. That one whack doesn't kill the cancer cell in completion, but daily whacking that treatment over the course of a number of weeks, you cause slow but persistent damage to the cancer cell that, just like all cells in the body, they kind of have their life expectancy. They kind of start a line and there's a finish line. And by hitting it every day at different parts in that life expectancy, you're damaging that cell to the point where it cannot repair itself. So once you've damaged it, it then goes on to die. So the purpose, we damage the DNA in the cancer cells. The cancer cells, as they're injured, are less able to repair themselves, and that effect builds over time throughout the course of treatment. So we talked about different types of radiation in that there's external radiation, and we talked about internal radiation. In external radiation, that's where you see this sort of divide and brings up this differentiation between what is photon radiation, which I refer to as the regular radiation, versus proton radiation. And we're going to talk a little bit more about those differences in a few more slides. But so external beam radiation is typically protons or photons. Internal radiation we refer to as brachytherapy, and that's what I explain, like the prostate seed implants or the GYN cancers where we're delivering radiation directly to, say, the cervix, that pelvis area. Or systemic radiation is another common, it's less common, I don't want to say less common. In my day-to-day, it is less commonly used, but it's commonly used and has been in use for decades. An example of a systemic radiation would be someone who has a thyroid cancer, and they may oftentimes, again, they would go in the hospital, be in a contained, you would be in like a normal hospital room, but they have you isolated where they're bringing you radioactive medication in a pill, you ingest that, and it selectively targets the thyroid gland, damages the cancer cells there. You're in the hospital for a couple of days while that peak radiation leaves. There's process for dealing with urine, feces, anything you touch within that room, and then you leave, and that's your treatment. So that's an example of systemic radiation. And keep in mind, I'm giving very simplistic explanations. Certainly, there are far more detail we can get into, but it's beyond really the main point of this, but by all means, ask questions. So when and why is radiation used? So more commonly, radiation is used, say, before a surgery. The purpose of that would be in the case of, hey, we want to try and shrink this tumor down, depending on the cancer type, respond differently to radiation. But there are times when we may give radiation with the intent that we're going to give radiation treatment and then the patient's going to go to surgery. There are times where radiation is given after the person's had surgery because the surgery was not able to take it all out at that time, or there were cells left on the pathology report. They call that a positive margin, meaning they got everything that they could safely take out and see with the naked eye, but along that rim of the tumor specimen that went to the lab, they found cells on this edge. So if what they took out has cells on the edge, the concern is, are there cells left behind in the place where they took it? So to reduce the risk of those cells trying to grow, that's a situation where we would commonly think of using radiation to reduce the risk of what we call local recurrence of that tumor. And it would be directed at where the tumor was before surgery and any of that high risk area where the surgery involved. It can also be used as a primary treatment. And there are times where the treatment is radiation alone. One simple example of that, many times, say skin cancers, the most common treatment for skin cancers is to just surgically take those off. The times where we use radiation as a single agent therapy would be, say, someone's having multiple skin cancers, or now if they were to have a skin cancer again on their face or that area, for the surgeon to do the surgery, it might cosmetically leave a bigger defect or be more complicated, requiring large grafts, things like that. That's a case where someone may be sent to us to consider giving radiation as the sole treatment, because other than really a sunburn right in that area on the face, the sunburn will heal, but it doesn't leave the patient with that significant cosmetic defect. So that's an area where radiation might be the preferred treatment choice. More commonly, skin cancer, surgery is number one. So the treatment process, you're referred to radiation center, you're coming in to meet the doctor, they're talking about radiation. What does that look like? What's involved? So there really are 3 steps to the radiation process. The first is meeting your physician and the team, having a consultation to review your medical records, understand everything that is the medical facts related to your cancer, and then also sitting down, having that one-on-one discussion with the patient and family to truly understand the physical side effects. What's the physical experience? Understanding those pieces related to the illness. From there, once the plan is made that, yes, this patient is appropriate for radiation therapy, and the patient has had their questions answered and agrees, yep, okay, this makes sense, I'm going to sign the consent to proceed. What comes next from there? Step 2 is really what we call simulation, and that's the planning process. Again, super, super important, because what we're doing is having you lay down on an imaging table to simulate or replicate how we would put you on the table and deliver the radiation. So for most patients, you're laying just flat on your back, arms resting on your chest or resting above your head or down at your side. We want you in a comfortable position so that every day, if you're coming in for 5 to 6 weeks, you can lay there for 20 to 30 minutes. And still, we need you to be still. So once we have you in the appropriate position, we do a CAT scan of the body part that's of interest. Those images go into our planning software, into the computers, and then that's where really a huge portion of the radiation is done, is in the planning process. And that's where it really is important to have the clinical expertise of the provider, that not only do they know the science behind when to use the tool and how to use the tool, they have kind of the life knowledge or the lived experience of using that tool in the clinical environment and understanding the variations that patients experience, because not all humans are identical, right? Most of us have pretty much the same body parts, but we're different. We're unique individuals. So then understanding all the pieces that make you unique, that you bring to the table, how do I use that information with the pictures to direct the radiation where we want and avoid the tissue we don't want it to go to? So the simulation and the planning piece is exceptionally important, because from there, once we develop that plan, that is the plan for the course of the treatment. The third and final step is the actual treatment itself. There is significant amount of time and energy spent in those first 2 steps, and it may take us, with proton radiation, that planning process from consult to starting treatment is often about 2 weeks. It's that much time, because it's not just the physician going through, directing, coming up with a plan, then it's going through a process of checks and balances that all the physics department, the dosimetry, the people who work with the physician to aim the radiation, that process of back and forth to come up with the safe and perfectly designed plan for you, that can take about 2 weeks to get done. Sometimes in situations we can go a bit faster, but most common things, side effects. And when I go over this side effect piece, this is broadly side effects of radiation. When I talk to patients about side effects of radiation, my story and describing what that's like is the same for protons and photons. The side effects of radiation are really guided by where we are directing the radiation. What body part is being affected? What is in the path of the X-ray beam? When a few slides longer, I will explain, well, what the heck is the difference between the two? I'll get to that. But in general, the description about side effects of radiation are the same. And as we talk to patients and consent them for treatment, that discussion about side effects is the same whether we're having a discussion about photon regular radiation or proton radiation. So if you think of it most simply as what body part is being treated, whatever is going to be affected, that's where your side effects are going to generate from. In addition to that sort of local side effect profile, we tell everybody to expect you may feel tired, a little more fatigued than you did at the start of treatment. Some of that is a component of the radiation itself. Your body on the inside is going through its own increased metabolism as it's trying to cope with inflammation caused by the radiation. It's already struggling to cope with fighting the cancer itself. So now we add in the physical changes with the radiation, but then there's the mental and the psychosocial piece, right? The stress, the come and going from the center. For patients that live out here and now have to go into the city, that adds another layer of stress. All those pieces contribute to someone experiencing fatigue during cancer treatment. So fatigue, skin irritation just in the target area are the broad, most common side effects. But when you think of targeting what body parts, so patients that get radiation to the head or the neck area, if you're treating the head, you may find that as the radiation builds up 2 to 3 weeks into treatment, you may have the odd mild headache. Your brain is tired. You may feel like you want to sleep a bit earlier, have a nap. Depending on the target area on the brain, we don't always treat the entire brain. Someone may have a brain tumor that's located just in one part of the brain. So we would target just that, not the entire brain. And in that targeting, you may find that, hey, I gradually get a patch of hair loss that develops throughout the course of treatment, where that hair may completely come out in that patch. More commonly, we tell patients that hair loss associated with radiation, it is likely to all come out, say on the head. Within 2 to 3 months of finishing the radiation, the body starts to regenerate, your hair will start to grow. Depending on the individual, sometimes that hair grows back a little different texture, maybe a little bit different color. And the pace at which it grows back can be different. So those are variations, but more commonly it will grow back. It just takes some time, a matter of months, or it may even be a year till you feel like your hair's closer to being able to have a full hairstyle, or you're not as noticing those changes. Anytime we're treating the head, you may find you may get queasy, nauseous. Some patients may vomit. When we're treating the neck area, if someone had a throat cancer and we're treating this area, well, what's here? You're swallowing, your throat, right? So it's like when you've had the worst cold, worst sore throat or strep throat of your life, that can be what it feels like when you're getting radiation. It doesn't come with one treatment, but 2, 3, 4 weeks into treatment, that level of inflammation and irritation on the inside of your swallowing tube can be like the worst sunburn of your life. And when you think of trying to swallow food and eat past that, it's uncomfortable. So patients that are treated to that head and neck area may need extra support in how do I get calories in when it hurts to swallow? How do I get fluids to stay hydrated? And there are different mechanisms to support that. The most extreme being maybe they need a feeding tube. Maybe they can't just push to keep enough calories and hydration just by drinking liquids, where they need extra support by having a feeding tube. We really try to be very cautious about using feeding tubes. There are times when it's needed. And again, I'm old enough to see this transition over time where we used to be pretty liberal, pop a feeding tube in somebody right away. But what they found is that it's a muscle. Swallowing is a muscle. There's certainly a lot of physical and psychological piece that goes into our society around eating, being in communion with people over meals and participating, talking. So it's not just a simple decision. Most concern is hydration and nutrition, but there's another facet to that treatment where we're more aware and more mindful of that impact. So although it is hard and challenging for patients to swallow with a terribly sore throat, we really try and encourage that because you're using those muscles. It's important to regain that swallowing function after treatment. When we're giving radiation to the chest or lungs, okay, I'm gonna ask someone shut out. What would you think would be a side effect if we're radiating your lungs or your breathing? What might happen? Coughing, right? Right. So, like if you had a cold, when you inhale a virus or a bacteria, it causes inflammation in the lung. The body is an incredibly made system. It's natural. It senses something's wrong. There's inflammation. I want to cough. Let's try and cough this out. Well, when you're getting radiation, not everybody coughs. Someone may come to us because they have a lung cancer and the cancer is causing them to cough, right? The body knows something's not right. There's an irritant. You're coughing a lot. As we treat the radiation and as we treat the tumor in the lung, we're causing inflammation, but in that process, we're also killing those cancer cells, and sometimes the cough goes away during radiation. So people that cough a lot coming in may find that the cough settles down throughout the treatment or beyond the treatment. People that don't cough coming in may start coughing throughout treatment, but that cough is more an irritant cough, and it will settle down and go away when the irritation from the radiation itself goes away. You may have shortness of breath. If we're treating over your swallowing tube, your esophagus, you may have heartburn-like symptoms, right? Your body senses there's inflammation. It may be uncomfortable as you swallow, or it may impact the bodies. You have like a control valve at the bottom of your esophagus that stops your stomach acids from coming back up. If we're treating near that, that control valve may not work quite as efficiently, so you may get more heartburn type symptoms. Even though you experience that during treatment, you tell people that's a temporary side effect. When the inflammation goes down, those symptoms will settle. Abdomen, commonly, what's here? So stomach, bowels, those are most common. Nausea, vomiting. You may pass more gas. You may have looser bowels. You may have more constipated bowels. Everybody is unique. How your body will tolerate the radiation is different, but we tell people, look, these are all the things that could happen. And as we're seeing you during the treatment course, because you get seen at least once a week by the provider, and you're seen by the therapy staff, and nursing staff is seeing you every day. Those are commonly things we ask. If we know we're treating your belly, we're going to ask you things related to how your abdomen is functioning, eating, passing your bowels, diarrhea, constipation. Patients getting treated in the GYN area, if you think what's down there, you could get vaginal irritation, bleeding, your bladder is down there, right? Even if the bladder was not in the treatment, your urine tube that comes out through that vaginal area to down in that general vicinity, that can be irritated, get a sunburn. And when that urine tube is irritated, you might get some stinging or burning when you pee. That's a temporary side effect, just like a skin irritation or sunburn side effect on your skin, it will go away. The same when we're treating in the pelvic area. Similar for the male pelvis. The guys do not get a free ride on this. If we're treating your prostate or down in the pelvic area, men commonly say, hey, I pee more frequently. I have some stinging or burning when I urinate. Any urinary symptom I had coming in seems a little bit more magnified or worse than what it did. So those are all common things. Again, temporary, should resolve when the inflammation from the treatment settles down. And usually that's within, you know, by a month out from treatment, you're feeling much better than you were on the last day of treatment. And within 2-3 months, you should be back to close to what you were before you got the radiation. And then if you think of musculoskeletal, so say I had a tumor, those, remember, sarcomas start in the bones or soft tissue. Say I had a sarcoma that was on my arm and I get treatment, I get radiation, and then surgery, they take it out. That tissue, the muscles, nerves in that area where I had radiation, they are different over time. We call it fibrosis. It's kind of scarring, tightening, stiffening of those muscles and nerves. So it's important, we tell patients particularly that have limbs or parts of the body, arms, legs, spine area on their back, it's really important for you to do stretching, to be using those extremities. We know over time things will tighten. Again, everybody's unique. The degree to which those will tighten, we can't control, but to help you live to the best of your ability, live with the best quality of life beyond therapy, that involves using those muscles, stretching them, keeping them pliable and in good shape. So managing side effects, common things, fatigue, it's sort of intuitive. When you're tired, you need to rest. But the caveat is, the more you sit, the more fatigued you are. If you are not moving, you will lose your strength and energy and all, not just physically, but mentally it impacts you. So we encourage you, alternate. It's okay to rest, but you can't spend all day sitting or all day laying in bed. Rest for 30 minutes, an hour, and then you get up and you're out. Even if you have 3 rests during the day, you're limiting your time that you're sedentary. In terms of skincare with radiation, I explained that you can get a temporary sunburn that develops where we're targeting the radiation. The sunburn, again, gradually comes throughout the course of treatment, depending on how long. Often it takes 2 or 3 weeks to start noticing any changes on your skin. When they start, it tends to be very mild to moderate suntan or sunburn. By the end of treatment, you may have, yep, my skin looks like a tomato. It's pretty toasty. But in terms of managing that, we tell you to use moisturizer lotion right from the beginning of treatment, throughout the course of treatment, using that at night before you go to bed. And depending on the degree of skin irritation you get, also helps us navigate, hey, maybe you should do that 2 or 3 times a day. Maybe we add in a prescription burn cream, depending on the amount of redness or irritation you're getting. But there are lots of things to help with that. And the skin will heal. Even when you have the worst sunburn of your life, you may have some blistering or peeling, but it will heal. Your skin may not look different to the broad general public, but you may notice, hey, it feels a little, texture's a little denser or firmer in the area I got radiation, or my skin there, I can see exactly where I got treated because I know where that sunburn was. But for the most part, it goes back to close to, if not completely back to what it looked like before the radiation. In terms of site specific, all those body parts, the breathing, the nausea, the changes in your bowel and bladder, those are all common throughout the course of treatment, but it's really important that you're talking openly and honestly with your care team so that we can understand, how do we support you to get through this course of treatment with the least amount of disruption and keep you feeling well, manage those side effects so that you don't need a break in treatment. As I explained in the beginning, part of how the radiation works is that low dose of daily giving you treatment every day, that builds kind of like a snowball, and then crescendos with the full effect, you continue that, and then 3-4 weeks after treatment, that crescendo effect starts to fall off and the inflammation heals. To give someone breaks in between, sometimes it's necessary. It's like we're walking a tightrope here. We want to push you to get you through, but we don't want to push you where now you're stopped treatment for 2 weeks because you're so sickly. That's not helpful for anyone. So it's really important that you're open and honest about the side effects you're experiencing and reach out to your team, because we can help manage most things quite well with medication and added support in the clinic to help you. So now we're going to get into the nitty-gritty about what is the difference between protons and photons. You may see commercials, you may hear friends or family that have had radiation or tell you about radiation. So I am a visual person. I think it helps me to understand. So in this top picture, this is a patient that was getting radiation to the spine. When we're treating the spine, if I was using protons, let me back up. So I talked about the machine delivering the X-ray at the target. So if this is my target, the machine delivers the radiation. With proton radiation, the beam comes in, and I have a good visual short video for you to watch, but it essentially paints the dose just at this target. With regular radiation or photon radiation, the energy that drives that X-ray is different. That gets more in the sciencey piece. I'm trying to keep it as simple, but with photon, regular radiation, when that X-ray comes in, it delivers the same dose, the same impact to the target, but because the energy is different, it delivers the dose, but then there's a little bit of scatter around the edge. So then another beam may come in from another angle, deliver the dose right on the target, but then again, a little bit of scatter. That is really the nuts and bolts about what's different with regular radiation, photon radiation, and proton radiation. With protons, we're able to deliver the radiation to the target with very little to no radiation to the surrounding area. So here's a visual. You're treating someone's spine. With protons, we can deliver the X-rays right to the spine target. That's this purpley pink. With photons, we can still deliver the dose we need to that spine target, but these colors down here represent low dose of radiation that's then exposed beyond the spine target to what's in here. Your lungs or your bowel is down here, so your other organs. So in simplest terms, where this is better is there's less radiation that goes to that surrounding tissue. Another example here on this one is, say the radiation's coming in from the back, able to deliver the target here at the spine bone, but what's in front? This is your heart. These black wings here are your lungs. This is as if someone's laying down on their stomach. So if this is proton, if you're using photons, delivering the same target to the spine, but if you see here, the heart area is getting a low dose of radiation. That low dose itself doesn't guarantee you will have a bad outcome or terrible side effects, but this is where having the wisdom and expertise to understand the person that's coming to us, to understand what is their unique set of other medical problems, other patient-specific history. Clearly, we don't want to give any extra radiation to any body part. But if someone, say, had a prior heart history and now they need cancer treatment, that would be a big deal for that person, because you don't want to add any other potential injury to the heart when their heart is already injured from a prior medical issue. So here's a video. Was there sound? Do you know if there's sound? There may not, there's no sound. Okay, so this is simulating, give you an example, the machine, the patient on the table, and how the machine delivers the x-rays. Machine moves around the patient. This is proton. And you'll see what I was describing, how it delivers it just at the target. You keep watching the video. It's short. It's only just over a minute, 2 minutes maybe. So here's an example of, there's the tumor. That's our target. And this is part of that simulation planning process. The doctor would have done all this planning in the machine to tell the proton machine, this is exactly where we want you to deliver that x-ray. When the beam comes in, it goes to the target and there's no fall off beyond the target. It's pretty incredible technology. It really is significant. And that's what our treatment rooms look like. You're in here. This would be the radiation therapist. The individuals who's working the machine, they do not come up with the plan. Your physician provider and that team comes up with the plan, but then the therapists are coordinating, getting the patient set up in the room, and then doing the checks and balances to verify patient is lined up exactly correctly, and then tells the machine, yes, go ahead and deliver the treatment. So I think this is just repeating the same video. So here's another example of where there are differences. So here are some different plans. One is proton, the other pictures are photon. So this is an example of a breast cancer patient, particularly with the left-sided breast, where the heart tends to be a little over on one side. So with protons, we're able to deliver the radiation dose to the affected breast. We do, in the planning, take account of how much, if any, radiation goes to the heart. And obviously we want to minimize that. So with protons, this is able to deliver the dose to the body part with very little to no radiation to the heart, and very little. This black is your lungs, and very low dose is actually going to the lung tissue. Now, your lungs can tolerate radiation. They're able to tolerate that without being irreparably damaged, but you want to treat the least amount of normal tissue as possible. So if we were treating that same patient with photons, again, we would be capable of treating this patient if they needed treatment with photons. But as you can see the difference, this green highlights that low dose radiation is exposed to more of the tissue, this lung and the heart. Lung and heart, you can see there's more color, there's more low dose radiation there. Again, this patient may or may not look or feel differently as a result of the treatment, but over time, you would worry about what's the consequence of exposing these body parts to radiation if we could have avoided it by using protons. Yes.
people choose the protons because that's what they're near, they're not near a proton.
Sometimes. And there are different reasons. That is one. I maybe can't get myself farther away to the proton center. Maybe I can. So sometimes it's what's available. Sometimes it's my providers or myself are not aware that protons is even an option. Protons is not the best tool for everybody, but it's at least in cases when you are diagnosed with a cancer, the benefits of protons by reserving normal tissue exposure, it's worth investigating. Would this be beneficial to me in my unique specific cancer treatment? You had a question?
So why did you guys choose, I've had both proton and proton. Why did you guys choose for my lung thing? Why did you choose to be ready for proton and not proton this time?
So I'm going to address that partly, but the short answer to that is it's really relying on the expertise, the wisdom and expertise and training of the provider to know when is the right time to use the tool. In your specific case, the best way to treat your spot was using the regular radiation, but that tool, we had a special tool, SBRT, stereotactic body radiation therapy, a way to deliver those x-rays that in that body part that we treated on you, it was better for you for disease, getting the radiation to the target and minimizing dose to the surrounding. It was better in your case to use the regular radiation tool. Using protons based on what we had to treat in you and understanding how that the proton beam moves in the body the way we needed it to move for you, it was not better. It actually would have treated more lung.
It's like stop breathing.
Yeah.
So, yeah.
Yeah. Yeah. That's why. So it really is, it's patient dependent. It's not a universal statement of someone may or may not be appropriate for protons, but it's really exploring what are my options, knowing that protons is a viable tool for many cancers when getting cancer treatment. So this is one example with breast cancer. Here's another with lung cancer. So in this case, this is the lung tumor, the red. And so this is the regular radiation. This is the proton radiation. So as you see, the biggest difference is we're still treating our target, getting the radiation dose to the cancer spot. We're causing that cell damage, tumor death. But in the process, if you look at the regular radiation, knowing how the beams come in from different angles, what's happening is in the process of coming in, it's leaving low dose, more tissue is getting low dose radiation exposure. So this is the regular radiation. This is the proton radiation. Even though, yes, there is tissue that is getting low dose radiation exposure, when you look at, even if you were to compare the amount of color from one side to the other, you can clearly see that, hey, there's more purple or more low dose over here on the regular radiation. Again, this is not necessarily the example for every single lung cancer, but this is a great visual to help you explain, look, I have the same tumor using those two different radiation tools, what gets the dose to the target with the least amount of surrounding normal tissue being treated. And in this case, if they were to have the same patient run the plan using both our machine technology, this would be a preferred treatment for that patient because less normal tissue. And when you think for this patient, because we're irritating the lung, they may still have all those same side effects I talked about, right? Cough, changes in their breathing, feeling of short of breath may be different. They may still get that, but their recovery and the magnitude of those symptoms may be a little less because really less lung tissue. All this side effect is really impacting their one lung where the other lung is completely spared, where here the opposite lung is also getting some radiation. And so here's another example in head and neck cancers. When you think of treating the throat area, which is, no, your throat is here, your brain actually comes close by. But in this case, our target is here within the throat. This is the back of the head. This is the patient's nose would be up here. This is actually their sinus, their nose sinuses. So when they're treating, again, our dose is going here to this red area. But if you look in the pictures, you can see there's a lot more color. This low dose exposure is going to that other tissue. This is a very dramatic difference between the two. As I said before, even though this is low dose of radiation, the patient's biggest side effect is going to be driven by treating that throat. This doesn't guarantee they have dramatically more side effects, but what we see in practice is, yeah, they probably do have more side effect with this regular radiation than the proton radiation. As you see, even here, sinuses, congestion, where you don't get that on the other. So yes, their main discomfort or bothersome with treatment is going to be the sore throat, the irritated, but adding misery to the experience, you know, my nose is stuffy. Now it also, like, I have trouble, feel congested, my throat's sore and I'm congested, right? If we can spare some of that for a patient, it makes a difference when you're the patient going through treatment. Another benefit, as we said, with that sparing of tissue with head and neck cancer patients, we talked about feeding tube use. And in using protons over photons, in the clinical research, they found that the need for having to support with feeding tubes was significantly lower. So the Proton Center itself, we've treated over 5,000 patients as of March 2025. The majority of our patient types tend to be breast, CNS, or GU prostate. But as you see on this side, we treat all different types of cancers, but these are the most common. Of all the more than 5,000 patients we treated, a small percentage were pediatric patients, and 13% were cases of reirradiation. Someone has had radiation in the past, they have a cancer recurrence, or they have a tumor, maybe they got treated, say they got breast cancer, treated, cured of their breast cancer, and years later get a lung cancer in the lung on the same side as their breast. Completely different cancer, unrelated, but now as we have to treat the lung cancer, we have to take into consideration they've had radiation to the breast. That would be a case where being able to use protons would be beneficial because we can reduce the amount of normal tissue that's exposed to the from radiation in a body part that already had prior radiation exposure from the breast cancer treatment. So another tool at our center that we use and that is becoming more common is something called hyperthermia, or we say heat treatment, in addition to using radiation. We do deep heat at the Proton Center, and then we also do what we call external heat, more superficial heating versus deeper in the body heating. This is talking about deep thermal therapy. And what that is, the patient would lay on the table. This is like a water bag. So you're laying down almost like a water bottle that lays on top of the treatment area. So here, imagine having your abdomen. Say you had a tumor in your belly. The purpose of the heat treatment is that by heating that tissue within the body where the tumor is, heating that to a low-grade fever temperature, maintaining that temperature for 45 to 60 minutes during the course of your treatment. So treatment Monday through Friday, weekends and holidays off. Heat therapy may be added in addition to your proton radiation, say 2 days of the week, to help build on the success of the radiation damaging and killing the cancer cells. That our clinical research has found that adding in heat therapy improves the ability of the proton radiation to kill the cancer cells. Now, heat therapy is not something that is used on every single patient, but at our center, these are part of all the tools we have in our toolbox that as we evaluate patients' unique case and what is the best use of all the tools that we have available to us, this is something that we're more commonly using and more patients are using heat therapy. So here's a better example of the patient is laying down. In this case, it's the abdomen area. They're laying, there's no needle in that process. They're feeling that heat therapy to measure the temperature of where we're treating on the inside, depending on the body part. Sometimes there's superficial temperature measurements, sometimes they're internal. It may be that they're putting a tiny temperature gauge, like a fine tube in the rectum or in the vagina to measure that internal temperature. They don't necessarily do that every single day, but in the first couple of treatments to gauge, yes, we are able to heat that body part to the appropriate temperature and sustain that temperature for the course of 45 to 60 minutes. In this example, here's our tumor. We're delivering the heat over that tumor area. And these are changes as we do sort of like heat maps of the tumor area to measure the impact of what's happening to the tumor in terms of blood flow that's going to the tumor throughout the course of treatment, from 10 minutes to trying to get you to 45 to 60 minutes, sustaining that heat. What they're doing is impacting the blood flow and ability of the radiation to damage and kill those cancer cells. This is a really fancy, colorful picture to explain heat therapy, but the most important piece is here. Why would someone use hyperthermia? Adding heat therapy twice a week during the course of the proton radiation can help augment the cell death caused during treatment. It also is another layer of insult on the cancer cells to damage the DNA. In the process of the tumor cell being injured, these fancy terms, heat shock proteins and lymphocyte tracking, the simple terms, it's causing changes within the cancer cell. It increases blood flow to the tumor area, which in patients that are also getting chemotherapy or in addition to radiation therapy, that impacts the body's ability to clear out dead tumor cells and inflammation around the tumor, and then also helps get in the body's natural immunity to attack the cancer cells. So again, this is a little high-tech and confusing. this is the most important piece to take away. It's another layer of insult and injury to damage the cancer cell to help build on our goal of killing the cancer cell so that it does not grow and come back. So anyone that knows of someone with cancer, has had cancer themselves, has gone online, and you hear lots of things. Some are truthful, some are not truthful, are more myth. So some of the common things patients come in and ask me over the years is, oh, I refuse to get radiation, or my family member had cancer, but they refused to get it because they were going to get terrible side effects. That is a myth. Not everybody who gets radiation has horrific side effects. Our technology has advanced. As we become capable of delivering radiation at the target and minimizing normal tissue surrounding the target, that also translates into more tolerable side effects for the patients. So most patients getting radiation have mild to moderate side effects. It is very rare for patients to become so sickly where they are in the hospital, though that can happen. But in those cases, usually it's also a component of something's going on with their cancer, where they are becoming more sickly, not just from the treatment, but also because of their cancer. Maybe they need other support. Maybe treatment of the cancer then triggered their blood pressure to go through the roof because nobody's looking at blood pressure and everyone's focusing on the cancer. So there's, again, lots of reasons why someone could become sickly during treatment, but majority of the time, patients tolerate treatment well. They can continue to work their jobs and come and go for treatment. You can be around your family. You can hug and kiss your family. You're not radioactive. You can sleep in the same bed as your partner without fear of exposing them to radiation. Again, that's the you are radioactive. Another is, oh, radiation hurts to get it. That's not commonly true. The radiation itself, when you're getting radiation treatment, it's like having an X-ray. How many people in this room have ever had, say, a chest X-ray or an X-ray of a limb for a broken bone? Anyone? Yeah. Did it hurt when you got your X-ray? No, you didn't feel it necessarily. So the times where could this be a true statement? Well, it's possible, but maybe it's because we're making you lie down on a table and be very still, and you had a prior back injury, and now we've aggravated your back. That could be painful. Most of the time, the radiation itself is not painful. Sometimes when patients come to us and they have a very painful tumor, the radiation actually helps reduce pain. The times where radiation can cause pain is if we give you a terrible sunburn, that can hurt, but that pain is temporary, and we are there to support you and give you, whether it's medications or non-medication things, to help manage that symptom of discomfort. Another common is proton radiation kills cancer cells better, and therefore I'm going to have a better cancer outcome because I use protons. And that is a myth. Now, there are reasons why protons are better, but the damage to the cancer cell between proton radiation and photon radiation, they are essentially the same. Where they can then differentiate between the two is depending on your unique case and understanding all the pieces of your story that come to us. It may be that protons does create better tumor killing because with that technology, we can get the radiation dose to a higher dose, which is what is needed to then kill the cancer, where if someone had prior radiation or they have something else that impacts, say the tumor is right beside the bowel or right beside another body part, where now we're limited on our ability to deliver the full radiation we want because we're worried about damaging that next door neighbor to where the tumor is. That's where protons may be the better, superior treatment tool. We have all those options that we look at. We have the benefit of having proton radiation at the proton center, but many of our, pretty much all our clinicians go back and forth from the proton center, also treating at the main hospital itself, the University of Maryland. So it's really having the knowledge and expertise to understand the patient's need, and then understanding what tools do we have at our fingertips and what is the better tool for your unique case. And depending on what it is we're treating, there are times when protons definitely is superior. Patients tolerate protons very, very well, even when we explain the side effect profile for photons and protons. And a common, as I said on that map, we treat a lot of prostate cancer or GU cancers. And so I would tell that prostate cancer patient, these are the side effects you would expect to experience: changes in bladder, changes in bowel function. Whether they got proton or photon, those side effect profile is the same. The guy with protons may not get quite as much stinging or burning of urination. He may get some, whereas the guy with photons might get a little bit more stinging or burning, or he may get up an extra time or two at night because of the irritation from our treatment than the guy who got photons. But ultimately, their long-term disease outcome, our ability to treat and control that cancer, we say is the same. And the research has shown, studied the prostate cancer patients, looking at outcomes, quality of life outcomes and disease outcomes, and that they're the same. But the proton patients, they probably have a little bit less side effects. They may tolerate it a little bit better. But overall, what matters most is, are we curing you of your disease? Are we controlling that so you go on to live well during and beyond treatment? And with all the tools available to us, protons has been incredible because it's allowed us to treat when patients had scenarios where we couldn't give the doses we wanted or able to get to body parts because of what's next door to where our treatment is aiming. So another big piece is the emotional impact of cancer treatment. And as I said, there's lots of physical side effects, but a big piece is the emotional impact of that. And what's very common is everybody is feeling fearful and worries about what's to come. How am I going to tolerate it? What's the outcome with my cancer? And I take every opportunity I can to help encourage patients to recognize that these things are normal. And the way to help cope with that is to be able to talk to people about it. Whether you have places like HopeWell, you have a community of support within different organizations, talking with your family, talking with friends, talking with other support networks. It's really, really important. And for us to be able to help you from the clinical side, we need to truly understand what you're experiencing, and that hopefully as you seek care at different providers, part of that decision on where do I want to center my care is really about that relationship with your provider, and how do you connect to that person? Do they listen to me? Do I feel seen? Do I feel heard in my experience? And don't be afraid to reach out for added support. Additional resources, Common Cancer Society, Allman Foundation is for young adults. We have HopeWell, which is outstanding. Keep Punching is a brain tumor specific organization. Most treatment centers have navigators or social workers also available to help. at the Proton Center, what's unique about another resource we have, which is outstanding, is our concierge program. And that is, we have a team of individuals that their role is, how can we help you navigate this cancer experience when you're dealing with our institution? We have patients that come from out of state. We have patients that come from different parts of the city. Maybe they need help figuring out transportation. Maybe our team can then identify what resources are already available that maybe you didn't even know were available. They can help coordinate appointments. If you need lodging, they have a network of relationships that they have built to help people identify places to stay. We have a partnership in Baltimore with Hope Lodge, which is owned by the American Cancer Society, but Hope Lodge and Ronald McDonald House are just a blessing to our community. This is not just a university, pardon me, of Maryland. Patients from Hopkins, all the surrounding hospitals, anybody can stay at those facilities, but our concierge team helps navigate all of that. For people that are from out of state, or, hey, I'm stuck in the city Monday through Friday, I've had my treatment, you're only in the center for maybe an hour or less a day. What the heck else am I going to do with the rest of my time when I'm stuck in the city away from home? And the concierge is a great resource to help with that, tell you about our area and how to connect you with that. The other piece, which is also very helpful, is helps us navigate when people are coming from practices outside our direct Maryland system. Also helps navigate those communication for us and ensures that information gets back and forth with those outside centers. Because our goal is all of us are here to provide care for the patient. It's not about the business side of it always, right? That's part of it, but it's really about the patient. How do we provide for the patient and give them the best experience? So our concierge program is fabulous. This is a little bit about Hope Lodge. They're currently in a fundraising to build an entire new Hope Lodge to expand beyond the 26 guest rooms. But that is a fabulous resource, free to cancer patients. There's a shuttle that goes back and forth from Hope Lodge to our Proton Center. But it is an outstanding resource owned by the American Cancer Society. And so that's it. Does anyone have any questions at all? Okay, I'm going to do one in front and then you're next. So they are laying on, they would go into the treatment room, which is not quite as big as this entire, but let's block off, say from the post to the windows, from me to the window. The patient is in that room, and within that room is they're on the table. The table moves to center with the machine, and then the machine moves around the table. They're laying still there for the treatment. When the treatment is done, the therapy team goes back in and helps the patient off the table, and they walk out. You are completely, yes, you're on the table and you're in a small donut. In the radiation room, in that proton room, totally wide open. You are not contained in a donut. It's open. You would see the machine itself moving around you, but it's not completely closing you in like your experience with the MRI. For patients that are claustrophobic, yes, that can be an issue to be in a room where the door is closed. But even when patients are claustrophobic, most patients can tolerate this because they're not contained or being in that tight space like a MRI machine. Mm-hmm. You had a question in the blue.
Yeah, I just wondered, in the cost, is proton similar cost to proton?
That is a fabulous question. Because this is a really important piece that differentiates our proton center. from other proton centers. So proton therapy as a science costs more money to deliver to patients. The technology, the machines, the workers that function behind the scenes to keep the technology functioning all has a higher price tag. What is unique about our proton center is that in its development, it really was about how do we provide this tool to our community rather than how do we make money for our center. Clearly, we need to keep the lights on, but our facility is what we call cost neutral. So when you come to us for proton radiation, and there is a bill, those codes go to your insurance company, whether you were getting proton radiation or photon radiation, that bill to the insurance is the same amount of money. We do not charge more for that technology. And that is different than some of the other proton centers. There are two outside of DC, and they have a different business model than our model. But for us, because we are cost neutral, that has helped us have 80–90%. You corrected me, it's now 90 is the correct? 93% insurance approval rate in getting our patients covered for protons. Because from the insurance end, let's be honest, right? They don't want to pay extra money. They're running a business. From the insurance side, they want to get the most for their money. And if they can get the same treatment in their mind, the same treatment with photons, why would they pay extra for you to get protons? For us, we're eliminating that. We're saying, look, give us the ability to use our expertise to determine what is the best treatment tool for you, the patient. And that helps us when we say it's protons, we can show them those color map differences to say, here, see for yourself, there is a difference in how much normal tissue is getting treated. And in addition to that visual evidence, we can say, and we're not charging you anymore. So now you tell me, Mr. Insurance, why are you refusing to give a treatment that is to help the patient? And so that helps us have a good approval rating.
You know, Medicare pays for proton therapy?
Yes, they do. They pay for protons just like they pay for regular radiation. It's the same amount of money. Yes. Yeah. Yeah.
For either proton or photon radiation, can it be used in the peritoneum?
Yes. With the caveat that is it possible for us? So the peritoneum is like the lining of your belly. Can we treat cancer spots in the lining of the belly? Yes. The question is that the best tool? Once you look at someone's unique case and understand the anatomy, exactly where it is, then differentiate, is that the right tool? But yes, in theory, can you treat cancer in the lining of the belly with protons? Yes. Yeah.
Is there any food restrictions? You have to have BNPO before you have radiation?
No, not at all. We want you living well, eating well, enjoying life. Now, that being said, say we're treating your belly and we're already giving you looser, more frequent stools. You sit down for dinner at a restaurant, you're looking at the menu. God, I'd love to have some chili. Common sense would say you're already having it. Could you eat that chili? Yes, but you might be paying for it a little bit later. So you can eat and drink what you want, but it really is guided by how you're feeling, your own side effects. But there's nothing you can eat or drink that is going to wreck what we are doing with the radiation. Yeah. Good question.
Yeah.
Yeah.
When I had the tongue and neck cancer, after the radiation or after surgery, and then 2 weeks later, after or during and after radiation, I had to be careful and eat like salt food and stay away from.
Spicy, yeah,
food that-
yeah.
And yeah, there's when in my mouth where I took some, they called it, what was it?
Like biotin,
But
something to help with your magic mouthwash, yes. Yeah,
and she gradually, the tongue, healed
yeah,
and all. But, I guess it was a bit uncomfortable while I was having this surgery. And at GBMC at that time, about 3 years ago, did not have the proton.
Yes. Yeah.
Proton surgery, was 30 treatments over 6 weeks.
yeah,
Yeah.
Yeah.
And so far, not only would I've been cancer free.
wonderful.
Fortunately, my sister has a cancer, and she lives in Clarksville.
Yeah,
I told Nancy I would come, and I think Nancy is looking at University of Maryland Treatment Center.
great, great. Tell her to come. There's a brochure you can take for the number. All she has to do is call and be happy to see her and evaluate all her medical records, but most definitely.
Thank you.
You're welcome. Anyone else have a question?
Are you from Canada?
I am. It came out. I am. Yes. Good catch. I was born and raised in Canada, but I've been in the US now since 94. So longer in the US than I've been in Canada, but it comes out. Yeah, it does.
Cool.
Thank you. But thank you everyone for coming. No, please ask.
About the,
Heat therapy, yes.
the first time that you were talking about ablation, but you said there's no.
It is different. It's not ablation. So, and I think that might have been one of I saw a question that mentioned ablation before someone had messaged in, but it is different than ablation. But you're right. It's a similar principle. With ablation, they're using like microwave heat to kind of burn that area, kill the cancer cells. With thermal therapy, it's a much less intense heat. You're warming that tissue area up to fever, like a 103, 104 degree fever, and maintaining that temperature in that body part for 45 to 60 minutes, with the goal that if patients can tolerate that, and most do, some patients say, I don't like how that feels. It adds too much in my time. Like it's not worth it for me. I don't have the time to spend. But for patients that tolerate it and get it, it's a way to build on what we're trying to achieve with the radiation. It doesn't guarantee you will have a better outcome, but it's, again, what are the tools that are available to me at this center, and how can I use those tools to get me the best outcome with my cancer? And so thermal therapy is a newer, it's an evolving science that we're using in addition to the protons, and it's been well tolerated and actually showing some good benefits in patients' experience, in their response to treatment, and their outcomes. With heat therapy, so it is not used in absence of radiation. It's used in combination with it. Yeah. Great questions.
So not necessarily the order that it goes, not necessarily that it's ordered it goes in, but like if the proton therapy didn't work, then you would do the heat.
The heat therapy, no, in certain cases, there are times where someone would come to us, and in making that assessment of what tools do we have, in addition to treating, we said this would be a case where adding in heat therapy might be beneficial to them. That unique case, not everybody with, I'm trying to think, someone we were just talking heat therapy had a tumor in the abdomen, deeper in the abdomen wall, sort of on the inside of the abdomen wall, and it met the criteria. Look, we can use protons to treat that. We can also heat that. So let's try and do both to help build on what we're trying to achieve to stop that cancer spot. Yeah. And it doesn't change the side effect profile. That's the other piece, is someone getting heat therapy in addition to protons, that same side effects story that we tell you you may experience based on the body part we're treating, the heat therapy doesn't make those side effects dramatically worse or dramatically better. So the biggest inconvenience is really on 2 days out of the 5 days I come for treatment, instead of being in and out in an hour, I might be at the center for 2 to 2.5 hours, because I have my treatment, which is an hour or less, and then my heat therapy, which adds an extra hour. Yeah. So thank you everyone for coming. Yeah. There are some of my cards there and some flyers on the Proton Center. If you have family, friends, people ask you about it, you can say, I heard a talk to this girl. I don't remember her name, but I grabbed her card. So give her a call if you'll never bother us. Yeah. Thank you.